And then there's one question, SSRI and olanzapine combination in bipolar 2. See, SSRI, olanzapine, that is like olanzapine, fluoxetine combination, which is mostly, see, like bipolar 2 as it is, I've shown very clearly. Most of the data, even in something like CanMed 2018, say that there are not much of studies exclusively done in bipolar 2. Whatever is applicable in bipolar 1, we are extrapolating to that. Nothing more. That's one sad thing about it. Maybe that can be, like an SSRIs and this one. Antipsychotics causing TD in bipolar. Yes. But sir, second generation antipsychotics are much less. Quetiapine does not produce TD. I have not seen. Olanzapine, I have not seen TD. This is the two drugs which we can give. Of course, we talk about metabolic syndromes, but TD is not very seen in that. Somebody asked about tripolar disorder. Sir, I am breaking my head with only bipolars. I don't want to go into tripolar. Sir, I don't know anything about this. Thank you. What is the harm prescribing mood stabilizer plus SSRI in bipolar 2? Number one, sir, there's nothing like mood stabilizer. I think we have to stop talking about mood stabilizer. Let us talk about prophylaxis. There's nothing wrong. There's nothing wrong in prescribing more so-called prophylactic drug and then SSRI or whatever it is in bipolar 1 because it's a definite diagnostic entity. Bipolar 2, why are you prescribing prophylaxis? For what? For prevention of depressive episodes or for prevention of hypomanic episodes. That's what, if it is for the prevention of hypomanic episodes, which are so minimal for a short duration without much of a clinical, like a social impairment, may not be worth it subjecting the person to such a long-term prophylactic drugs. That is what I see that. We misdiagnose depression or RDD as bipolar 2 because most of us feel we should not introduce iatrogenic switch, believe in the same. Can you give? Absolutely, sir, absolutely. This is what I was talking about. I think there is a pervading kind of, the insecurity among the psychiatric community. As I told that, every depression, this could be bipolar. Second episode, this could be bipolar. This could be spectrum. So if I give SSRIs, the whole lot of, I'm now like in so-called switch, rapid cycling, acceleration, all those things happen. That is why I very clearly told that. Even if it is a bipolar disorder, I misdiagnose, I don't diagnose. It is, I do not mind he will have a next manic episode because at least my diagnosis is correct. Number one, sir. Number two, I don't know how many of you agree with me. Acute episode management, we are doing an excellent job, whether it is bipolar depression or mania. When it comes to prophylaxis, I don't know. Maybe those few patients who are lithium responders are doing extremely good. Rest of it, sir, we're not doing a good job. So that is where that fear. That's what I told him, that everybody wants to be the fantastic clinician and making the best diagnosis. So I make a diagnosis of bipolar disorder on every depression. I have no problem at all. Even after 15 years, his fellow becomes bipolar disorder. Oh, I have diagnosed that time. No, that's not the way to treat. Absolutely, that's not the way, sir. I don't want to offend anybody. But that should be that. Why are we so scared of it? What about the suicidal risk? What about the suicidal risk? Ultimately, we give all these drugs natural course, they improve, and then it goes on. No, there has to be a kind of systematic thinking behind it. It's okay. It's okay. He switches into bipolar. We are all worried. But borderline personalities, that's what absolutely. One very, very sad thing is borderline personality disorder being diagnosed as a bipolar disorder. Here, some of the so-called educated Google doctor patients walk into your clinic saying that, doctor, I have mood swings. I get into feel low, dull, depressed, worried. I get extremely irritated and all those things. 1 week, does it last? No need. We have ultra rapid cycling, ultra diane cycling. I have a case which he has taken from the textbook. You feel like crying on a 5-year-old child. The diagnosis of bipolar disorder has been made, taking that as an ultra diane cycling. What are we doing? That is where the problem is. How can personal disorder? But we do, but not like the point is, if there is effective treatment for bipolar disorder, effective prophylaxis where you can say fairly at least 50-60% saying that the next episode will not be there, at least not much. But we don't have today that much of tools. So we cannot just know like in 2 days of whatever the mild abnormality, what is the hurry to make a diagnosis of hypomania, and then what is the hurry to conclude it as bipolar 2, and what is the hurry to start him on valproate? What is the hurry? That's what my question is. I've been asking, and I think very clearly the literature also is now talking about it more and more, more and more. We are doing more harm to patients by prescribing this long-term treatments. One of the series, I'm going to talk about it. One of the main reasons, the block between a symptomatic recovery and then functional recovery is that iatrogenic drug-induced adverse event. Second is cognitive impairment. I'll show you that study. We are doing that, which is not justified. Right, sir. Okay. Postpartum psychosis. All postpartum psychosis are, one second, sir. Early signs to differentiate BPD versus, I don't talk about early bipolar, so there's nothing like that. You have a clear episode. Early differentiate borderline personality. Borderline personality disorder, as I was telling, that it's very difficult. But what are the definite diagnostic criteria for borderline personality disorder? Not like you have lots of things, unstable, the whole lot of things, But I say that unless you're very sure about the bipolar disorder, don't commit onto this. Wait. By waiting for 1 or 2 manic episodes, we don't lose anything, rather than subjecting the borderline personality to so-called prophylactic drugs. That's the only thing. Early detection, I also don't know. What is your opinion? All postpartum psychosis are bipolar disorders. This is again one of the things which been talked about, but all may not be so. Maybe mostly we can say that, not all. Here, I think somebody talked about postpartum. This is one of my favorite bashing points. You diagnose a patient with bipolar disorder, you will never know. None of us can predict when the next episode can be. Am I right, sir? None of us can predict, fairly certainly. But the only situation where majority of the times we can predict that there's going to be an episode is postpartum episode. If a lady had a bipolar mode episode prior, I feel almost 100%, maybe 90 to 100%. Postpartum, there's going to be a recurrence of that episode. This is what the challenge I keep talking about. If you have, give me one prophylactic drug, lithium valproate, whatever you name it, I'll use it. Can it prevent the next postpartum? If there is one drug which can prevent effectively, at least in 60-70% of the patients, the postpartum recurrence of the episodes, that is the proof of a good prophylactic drug in bipolar disorders. I'll take it, but we don't have it. That is what the problem is. But I cannot say that the whole lot of things are not like in bipolar. How efficacious lamotrigine BPAD prophylaxis? Lamotrigine is a very safe drug, sir, but for that rash and then Stevens-Johnson's. And if you ask me, it is supposed to be, what is that, type B mood stabilizer, specifically. Let me spend a minute here. Specifically for the prevention of depressive episodes. Now, it's a all of us accept, it's a well accepted fact that even though bipolar disorder, mania is the signature episode, the most common episodes are depression. For every single episode of mania, it's a 3:1, 3 episodes of depression. Majority of the time in bipolar disorder 1, I'm talking about, they spend in depression. Most of the morbidity is in depression. Mortality is in depression, that is suicidal risk. So if there is one drug which can prevent the next depressive episode of my bipolar disorder, I really welcome that. That's the most important thing what I want. So lamotrigine, theoretically, if it is doing that, it would have been an excellent drug. Every patient will be, we'll be writing on that. But I'm not that confident about that drug. I do write, but can you say that, okay, right, I look for something like this. You give an antidepressant for somebody with melancholia. After 3 weeks, you'll be all right. Acute mania, don't worry, 2 months maximum, I'll get you all right. That kind of a confidence, I give lamotrigine. Can the episodes be prevented? I'm not very sure. But it may be a long term, as I know that now 10 years, 4 episodes, we have to really wait and see that, but definitely I can't say that. Some of the higher suicidal risk of BD could be attributed to undertreatment of depression. Most studies need to be conducted by excluding the. This is exactly the problem. Absolutely right. Suchita, I think Dr. Suchita Agarwal, you hit the bullseye. On one side, we talk about depression being the morbidity episodes, mortality episodes. And on the other side, there's a huge controversy on it. All of us are morbidly scared of, every psychiatrist is scared of prescribing an SSRI. No, SSRI need not be. What is the suicide prevention efficacy of quetiapine? Anybody tested? No. The only drug is that lithium. Lithium is not an easy drug to use, number one. We talk about being gold standard, but lithium, I'll show you one of this. Lithium usage has been coming down. So we need to find an effective treatment for the bipolar depression, whatever it is, and which is, we can take it with a little bit of a risk. That's why switch all the time we talk about. That's why I showed those 2 slides. Over a period of 20 years, switch is 8%. For the sake of 8%, you're not treating 92%, which is not correct. I think you're absolutely right. How effective lamotrigine for acute? I don't even think, sir. I want my patient with bipolar depression to come out of it at least in 2 months. For me, it takes at least 2 to 3 months to build up the dose of lamotrigine, so I don't think about it. Prophylaxis, definitely we can give it a try. Yeah, I think we are slowly deviating from bipolar 2 to mood stabilizers along with antipsychotics. Drugs help in mania, certainly, sir. But I also would request you to try only antipsychotics. I know I'm talking maybe all not very like in textbook descriptions or what is generally accepted upon. This is what I do. Try antipsychotics alone. They help. They become better. No problem.